In this lecture, we're going to look at the hand. So first of all, we're going to look at the dorsal aspect of the hand, and we'll look at some of the extrinsic extensor tendons that originate from muscles in the forearm and pass on to the dorsal surface of the hand. We'll then look at the anatomical snuff box, which we mentioned in the previous lecture, and we'll also look at the tenderness sheaths. We'll then move on to the palmar aspect and look at the carpal tunnel, where some important flexor tendons from extrinsic muscles pass through. We'll look at numerous compartments within the palmar aspect of the hand. We'll look at the muscles and then the extrinsic flexor tendons. So here we can see the dorsal aspect of the hand. It's the posterior surface. We've got the thumb over on this side, so this is the lateral aspect. And here we have, with the fifth digit, we have the medial aspect. We can see we have the extensor retinaculum here, and we can see that tendons from the extensor muscles in the forearm are passing deep to this structure as they pass into the dorsum of the hand. And this extensor retinaculum is an important thickening of the antebrachial or the forearm deep fascia. It prevents them from bowstringing. It prevents those extrinsic tendons from bowstringing. We can see that we have the tendons of extensor digitorum and extensor digiti minimi and extensor indicis, all passing through this tunnel which is created dorsally to the wrist. So between the carpal bones of the wrist and the extensor retinaculum, we can see the extensor digitorum tendons here, we can see extensor digiti minimi here, and we can see extensor indicis passing all the way to the index finger. Each extensor expansion covers the dorsal aspect of the metacarpals and phalanges. And these extensor expansions are triangular shaped aponeurotic hoods that lie over the dorsal and sides of the metacarpals and phalanges. And it is these that the tendons of extensor digitorum, extensor digiti minimi, and extensor indicis pass to. We can see, if we look at the tenderness sheaths, that they actually divide into two tracts, and they pass to both the middle phalanx and the distal phalanx. So we can see here we have the medial tracts that are passing towards the middle phalanx of each digit, and then we have the lateral tracts which are passing towards the distal phalanx. And these are specialized tracts of the tenderness of the extensor expansions that pass over the dorsum of the digits. This means that you don't have as much control over the extension of the digits, and it tends to act as one. You have less ability to extend the individual interphalangeal and metacarpophalangeal joints as you do with flexion, and they seem to act as one smooth movement. We can see that adjacent tendons from extensor digitorum are joined by some obliquely running interconnections. We have three of them running between the long tendons that are passing towards these extensor expansions. And like I say, this helps to limit the independent extension of the fingers. So it's very difficult just to extend one finger. You either extend them all or you don't. Because you have extensor indicis, this does offer this specific finger a certain amount of independent control. So I mentioned the anatomical snuff box when we spoke about the forearm in the previous lecture, and I just want to talk about it a little bit more here. It's formed by those outcropping deep muscles that come from the extensor compartment of the forearm. And they create, the tendons of these muscles, create a shallow depression on the lateral aspect of the hand. So here we can see the thumb, and here we can see we have the anatomical snuff box. We can see its borders. So medially, we have a border here, and this border is formed by EPL, extensor Pollicis longus. So that forms this medial border. And laterally, it's formed by two tendons. The tendons extensor pollicis brevis, which we can see here, extensor pollicis brevis, and also the tendon abductor pollicis longus, which is a little bit harder to see in this diagram, but would be running alongside extensor pollicis brevis here as it passes towards the thumb. So laterally we have two tendons, extensor pollicis brevis and abductor pollicis longus, and medially we have one tendon, extensor pollicis longus. This space in between these tendons is known as the anatomical snuff box. The floor of the snuff box is formed by two carpal bones, and these can be palpated, the scaphoid and the trapezium. These two carpal bones can be palpated, and it contains the radial artery. So when we look at the blood supply to the hand, you'll see that the radial artery runs over this anatomical snuff box. You can also palpate the styloid process from the radius, quite proximally within the space, and the base of the first metacarpal distally within the space. So it's important you recognise the features in the anatomical snuff box, and as the scaphoid bone is prone to fracture, palpation here and eliciting pain could indicate a fracture to this carpal bone. So the anatomical snuff box. Let's look at the tenderness sheaths that I mentioned as the extensor tendons pass through the extensor tunnel, really, running between the carpal bones and the extensor retinaculum. Again, on this slide, on this picture of the hand, we can again see the extensor retinaculum here. We can see the medial aspect down here. We can see the lateral aspect down here with the thumb. Now we can actually clearly see the two tendons that make up the lateral border of the anatomical snuff box, both extensor pollicis brevis here and abductor pollicis longus. So now we can see those two tendons. And what you can recognise is that as these tendons pass deep to the extensor retinaculum, they have within them, they're surrounded by a tenderness sheath. And we can see that here if we look at a section through the wrist. This is going to be the dorsal aspect, and this is going to be the palmar aspect. So we're not really worried about this side for the moment. But we can see we have the skin here, we have the extensor retinaculum running between the skin and these tendons. And these tendons are tightly held against the carpal bones. So we have these tenderness sheaths so that the friction within these osseous tunnels is reduced. They reduce the friction within the osseous tunnels. Here, with some added detail, you can see the plane of the section through the wrist. Here we've got the extensor retinaculum again. And you can see that these tendons are surrounded by an individual tenderness sheath. So as the tendons cross the dorsum of the wrist and they enter the hand, they are covered by these synovial tendon sheaths. This reduces the friction within the osseous tunnel created by the extensor retinaculum spanning the radius and the ulnar. So the friction as these tendons, as the muscles are contracting and the tendons rub alongside the carpals, is reduced by the presence of these tenderness sheaths. So these are very important. So now let's move on to the palmar aspect of the hand. And the palmar aspect of the hand contains a whole series of intrinsic muscles that allow the hand to assume many different positions, and also the tendons of the extrinsic muscles that originate in the forearm and pass through the carpal tunnel to the hand. Again, on the slide, we can see we've got the thumb, we've got the second, third, fourth, and fifth digit. So here we have the lateral aspect, and here we have the medial aspect. We can divide the palmar aspect of the hand into a number of compartments, and we can identify numerous muscles within those compartments. So here again on the slide we have the picture. We have this nice central compartment that contains mostly some deep muscles, but also the palmar aponeurosis. And the palmar aponeurosis is continuous here with the antebrachial fascia. It also connected to a long muscle within the forearm, palmaris longus, and this helps to tighten this palmar aponeurosis. The palmar aponeurosis is important for protection. It's also important in being able to form the grip. It tightens the skin when you're forming a grip. So, another space we can see is known as the Hypothena Eminence. The Hypothena Eminence is located medially within the hand, and we can see there's a collection of muscles here. So the Hypothena Eminence. Then we have the thenar eminence. That is associated with the thumb. So we can see the thenar eminence here. We then have a small adductor compartment, which is just here, in between the thenar eminence and the central compartment. And then deep in between the metacarpals, we have an interosseous compartment. And we're now going to explore all of these individual compartments. Let's have a look at the palmar fascia, first of all, and look at the palmar aponeurosis. And we can see that the palmar aponeurosis is running over the whole palm, but it is actually thin over the hypothena and the thenar eminences. So it's thin laterally, it's thin medially, but it thickens centrally, and this is where we have this triangular shaped palmar aponeurosis. The apex of the palmar aponeurosis here is continuous with the palmaris longus muscle, as I mentioned, and distally it forms 4 longitudinal bands. And these longitudinal bands pass over the digits and support the digital sheaths that enclose the flexor tendons of flexor digitorum superficialis, FDS, and flexor digitorum profundus, FDP. Remember, these muscles are originating in the forearm and they're passing through the central compartment deep to palmar aponeurosis to pass to the digits. And these muscles are enclosed by the digital sheaths. And these longitudinal bands help to support those sheaths. So let's now look at the thenar eminence. This collection of muscles is associated with the thumb. We can see the thenar eminences here. What we've done is we've removed the palmar aponeurosis on this diagram, so now we can just concentrate on this space here, the thenar eminence. The lateral aspect of the palm, the thenar eminence, contains 3 muscles: Aponeurosis pollicis, Adductor Pollicis brevis, and Flexor pollicis brevis. These muscles are primarily responsible for opposing the thumb, for opposition of the thumb, so it can assume a very unique position where you can draw the thumb across the palm of your hand, opposition. We can see these muscles here. Deep within the thenar eminence, we can see Aponeurosis pollicis. We can see this muscle here, Aponeurosis pollicis. And then we can see that what's being cut are 2 muscles. We have Flexor pollicis brevis here. Flexor pollicis brevis, we can see the 2 cut ends of it here. So we have this muscle, Flexor pollicis brevis, and we have the other part of it here. And then more laterally, we have Adductor pollicis brevis. So we can see Adductor pollicis brevis here, and we can see where it's been cut here. You also have a slightly deeper head to Flexor pollicis brevis, and we can just make that out deep. It's at the same plane as Aponeurosis pollicis. So these are the 3 muscles that are within the thenar eminence. We can see the muscles here in this table, highlighting their origins and insertions, and all 3 of these muscles come from the flexor retinaculum and specific tubercles of the scaphoid and trapezium bones. So all of these 3 muscles have a common origin. Aponeurosis pollicis inserts onto the lateral side of the first metacarpal. Adductor pollicis brevis and Flexor pollicis brevis attach to the lateral side of the proximal phalanx of the first digit. So just make sure you're happy with the origins and insertions and refer back to the diagram if necessary. All of these muscles, your thenar eminence, are supplied by a branch of the median nerve, and this is known as the recurrent branch of the median nerve. This nerve runs very superficial and can easily be damaged. But these three muscles are supplied by the recurrent branch of the median nerve. The function of these muscles really is as their name suggests. So Aponeurosis pollicis helps to oppose the thumb. Adductor Pollicis brevis abducts the thumb and also supports opposition. And Flexor Pollicis brevis helps to flex the thumb. You should make sure you're happy with the movements of the thumb. So now let's move to the adductor compartment. The adductor compartment only contains one muscle, and this is important in adducting the thumb, as the name suggests. But there are two heads to the adductor pollicis muscle. There is an oblique head and there is a transverse head. And here on the diagram we can see we have this adductor pollicis muscle here, this triangular shaped muscle. It actually runs underneath here the tendons of flexor digitorum profundus and the lumbricals, which we'll come back to. It's running deep to those, but it's passing out from the central region of the palm. It's passing out towards the thumb, and it's got two heads. The more transversely orientated part of the muscle is the transverse head. The more obliquely orientated part is the oblique head. And these two heads converge onto a common insertion point. So the adductor pollicis, its oblique head comes from the base of the second and third metacarpals and also the capitate bone. The transverse head comes from the anterior surface of the third metacarpal. So we can see the origin of the two heads. A common insertion onto the medial side of the proximal phalanx of the thumb, and this is supplied by the deep branch of the ulnar nerve. As its name suggests, this muscle adducts the thumb, so it draws it closer towards the palm of the hand. Now let's move on to the Hypothena Eminence. The Hypothena Eminence is located on the medial aspect of the hand, and we can see we've got a collection of muscles here. Like the thenar eminence, there are going to be three muscles within the Hypothena Eminence. Three muscles: Adductor digiti minimi, Flexor digiti minimi brevis, and Aponeurosis digiti minimi. Now, if we have a look, we can see that these muscles form a similar arrangement to that of the thenar eminence, in that some are deeper to others. So let's have a look. First of all, we can see Adductor digiti minimi here, and we can see where we've cut it off. It's the most superficial muscle, but we can see its two parts there. And then deep to this muscle, deep to Adductor digiti minimi, we find we have Flexor digiti minimi. Sometimes this can be called brevis, like I've included in the text here, but as we don't have a longus version of it, it's not necessary, and it can just be Flexor digiti minimi. And then next to it, we have Aponeurosis digiti minimi. So these are the three muscles that lie within the Hypothena Eminence. Adductor digiti minimi, you can see it's been cut here, passing along the most medial aspect. Deep to it, we have Flexor digiti minimi, and then slightly lateral to that, we have Aponeurosis digiti minimi. Within the subcutaneous tissue over the Hypothena Eminence, there is a small muscle over the Hypothena Eminence, and this is known as palmaris brevis. We can't really see it here, but palmaris brevis is an important muscle, and it helps, along with palmaris longus, to tighten the palmar fascia, and this helps supporting of the grip. So if we have a look at the origins and the insertions for these muscles, well, here we have the muscles, Adductor digiti minimi. This is originating from the pisiform bone, and it inserts onto the medial side of the proximal phalanx of the fifth digit. So we're just concentrating on the fifth digit now. This muscle is supplied by the ulnar nerve, so it's no longer the median nerve. We've moved over to the medial side of the hand, and we're now supplied by the ulnar nerve. Specifically, it's the deep branch of the ulnar nerve. As the name of the muscle suggests, the function of Adductor digiti minimi is to abduct the fifth digit. Flexor digiti minimi, or adding brevis if you want to, originates from the hook of the hamate and also the flexor retinaculum. It shares an origin with the opponens digiti minimi muscle. So these two muscles share a common origin. However, they have a different insertion. Flexor digiti minimi brevis inserts again onto the medial side of the proximal phalanx of the fifth digit, whereas opponens digiti minimi inserts onto the medial border of the fifth metacarpal. But all of these muscles have the same nerve supply, which is the deep branch of the ulnar nerve. Again, the function of these muscles is indicated by their name. So flexor digiti minimi flexes the proximal phalanx of the fifth digit, and opponens digiti minimi rotates and draws anteriorly the fifth metacarpal. It helps to oppose the little finger, and it helps to draw the little finger towards the thumb so these two digits can touch one another. So now let's turn to the carpal tunnel. Very similar to the arrangement we had on the dorsum of the hand, at the wrist joint, where we had the extensor tendons passing between the extensor retinaculum and the carpal bones. But this time we're looking at the flexor retinaculum, and deep to the flexor retinaculum are a series of tendons from those long extrinsic muscles in the forearm that are passing through this carpal tunnel towards the hand. And we can see these here. We can see the flexor retinaculum in this section, and we can see we've got the tendons here surrounded by a flexor sheath. And we can just talk through these tendons. So the long tendons of extrinsic muscles enter the hand through the carpal tunnel. This carpal tunnel is formed by the flexor retinaculum and the concave palmar aspect of the carpal bones. So the way the carpal bones are arranged is that along their palmar surface, they are actually concave. And then with the flexor retinaculum passing over, they then create this tunnel. Includes the flexor tendons of flexor digitorum profundus, flexor digitorum superficialis, and flexor pollicis longus. So the tendons of these forearm muscles, these extrinsic muscles, pass through the carpal tunnel. And we can see these here. In this diagram with the carpal tunnel opened up, we can see the tendons of flexor digitorum profundus here. And these are passing towards the palm. If we look here, we can see the cut tendons of flexor digitorum superficialis, and these also would have entered through the carpal tunnel. We can see that here. We have the more superficial tendons of flexor digitorum superficialis, and then deeper between those tendons and the row of carpal bones here, we can see flexor digitorum profundus. We can also see flexor carpi radialis tendon here, and we can see flexor pollicis longus tendon here. So we can see these tendons passing through the carpal tunnel. We can also see that we have the median nerve, and we can see the median nerve is deep to the flexor retinaculum. So if you were to have swelling within the sheaths, overuse of the tendons perhaps, irritation of the tendons could lead to inflammation and swelling, and that could push the tendon against the tight flexor retinaculum, and you could develop carpal tunnel syndrome. We also have passing superficial to the flexor retinaculum, we have the ulnar artery and nerve. And this is within a region known as the ulnar canal. So also running towards the hand, we know passing towards the hand has to be the ulnar nerve because it supplies those Hypothena muscles. But importantly, the ulnar artery and its accompanying nerve do not pass into the hand via the carpal tunnel. We can see here that they lie above the carpal tunnel, superficial to the flexor retinaculum. So these do not, in fact, run within the carpal tunnel. So now let's move on to the short muscles and how they're arranged alongside the extrinsic tendons. So here we can see some deep dissections of the hand. We can see that we've cut away some of the tendons and we've opened up the carpal tunnel, and here we've removed some of those tendons as well to look deep and see some dorsal and palmar interossei muscles. So if we have a look, we can see that all 8 tendons, see them here, flexor digitorum profundus, and we can see the cut tendons here, flexor digitorum superficialis, enter to the central compartment of the hand by passing through the carpal tunnel. And if you remember, FDS, flexor digitorum superficialis, pass to the middle phalanx of digits 2 to 5, whereas FTP, flexor digitorum profundus, pass to the distal phalanx of digits 2 to 5. So there's an important arrangement here that we need to observe. As the tendons of flexor digitorum superficialis pass to the middle phalanx, the tendons actually split, and we can see that here. Here we can see the tendon of FDS passing towards the middle phalanx and its tendons splitting. See it here? We can also see it happening here. See the tendons splitting into 2 as they go and attach to the middle phalanx. We can see it again here once these tendons have actually been reflected somewhat. See the tendon of flexor digitorum superficialis here, and we can see it's actually split, one going down onto this lateral side and one just going down on this medial side. It's a little bit covered by this, the tendon of flexor digitorum profundus. The tendon of flexor digitorum profundus, as we can see, passes deep through this split. So as the tendon of flexor digitorum superficialis split, so the deeper tendon of flexor digitorum profundus passed through this split as it passed to the distal phalanx. And this is a really important arrangement. We can see it again here. Flexor digitorum profundus is passing deep to flexor digitorum superficialis. And then as it splits, the tendon here is splitting, FDP passes deep to it. And this enables the tendon of FDP to pass to the distal phalanx. We also have some Vincular Tendinum. We have 2 of these, and these are very small little slips of tissue, and they actually attach the tendons of FDP and FDS to each other and also to the phalanx. We can see these small little tendinous slips. We can see them passing down here. And here we have a longum and a brevia. We have a long one and we have a short one. And these are important in connecting those 2 tendons to the tenderness sheaths and also in permitting some microcirculation. So these carry some micro blood vessels to the tendons for their blood supply. So they're really important in connecting the tendons to each other and also to the phalanges, and also permitting some microcirculation so the tendons can receive their oxygen and nutrients. So if we now move on to the short muscles of the hand, we can see that we have a whole series of what are known as lumbricals. We have lumbricals going from fingers 2 and 3. These are known as lumbricals 1 and 2. And lumbricals going from fingers 4 and 5. And these are known as 3 and 4. So we can see these lumbricals here. We've got a lumbrical here. We've got a lumbrical here. We've got a lumbrical here. And we have a lumbrical here. And these lumbricals are coming from the lateral 2 tendons of flexor digitorum brevis, and they're coming from the medial 2 tendons of flexor digitorum profundus. So now let's turn to a series of short muscles known as your lumbricals. And we can see the lumbricals here. We have 4 of them. And the lumbricals are either unipennate or bipennate in arrangement. They either have one kind of head or they have 2 heads originating from different places. And we can see we have a unipennate lumbrical here. And this lumbrical is important. It's coming from the tendon of flexor digitorum profundus. So all of the lumbricals come from the tendons of flexor digitorum profundus. And as they run over towards the extensor expansion, they are running over the metacarpophalangeal joints and then over the interphalangeal joints. So these muscles are capable of working across 2 different joints. We have a lumbrical here. We have another lumbrical here. Our 2 lateral unipennate lumbricals. And then we have 2 bipennate lumbricals. We can see we have one here and we have one here. So we have 4 lumbricals together. Notice how they all originate from the tendon of flexor digitorum profundus, and they don't work on the thumb. They don't work on the first digits. They're only associated with digits 2, 3, 4, and 5. So if we have a look, we can see lumbricals 1 and 2. These originating from the lateral 2 tendons of FDP, and these are our unipennate ones I indicated. And then we have lumbricals 3 and 4, and they're originating from the medial 2 tendons of FDP, and these are bipennate. They insert onto the lateral surface of the extensor expansions, as I mentioned, of the digits 2 and 5. So they don't work on the thumb, just digits 2 to 5. The lumbricals 1 and 2, the lateral 2 lumbricals, are innervated via the median nerve, whereas the lumbricals 3 and 4, associated with the medial tendons of FDP, are innervated via the ulnar nerve. So we can see the lumbricals have a different innervation, a different nerve supply. The function of these lumbricals is important because they can both flex and extend different joints. So they can flex the metacarpophalangeal joint, the joint between the phalanges and the metacarpals. So they can flex that joint, the phalanges here and the metacarpals, they can flex that joint. And they're also capable of extending the interphalangeal joints. So they're capable of flexing that joint, but also extending the interphalangeal joint. And that is because of their position. They run anterior to the metacarpophalangeal joint, so they can flex it. And by passing to the extensor expansion, they're running posterior to the interphalangeal joints. So contraction of these muscles allows flexion of that joint, the metacarpophalangeal, and extension of the interphalangeal joint. And this position here is important if you're holding a pencil, if you're about to write. So these muscles are important for the digits to assume complex positions. Now let's carry on looking at a series of short muscles, and these are known as your interossei muscles. We have 2 different types of interossei muscles. We have dorsal interossei positioned on the dorsal aspect of the hand, and we have palmar interossei muscles positioned on the palmar surface. Here we can see the dorsal interosseous muscles. We have 4 of them. We can see 1, 2, 3, 4, and we can see these have 2 heads. They're running from the adjacent surfaces of all of the metacarpals. So we can see the dorsal interosseous here is running from the medial surface of the first metacarpal and the lateral surface of the metacarpal here, of the second metacarpal. And we have similar arrangements. And these are passing towards the extensor expansion, those extensor hoods over the digits. And then we have the palmar interossei. These are just running from one of the metacarpal surfaces, and we can see they're coming from digits 2, they're coming from digits 4, and coming from digit 5. Digit 3 does not have an attachment of these interossei muscles. The interossei muscles do not attach. So we can see that these muscles are going to be associated with abducting and adducting the fingers. We can see the dorsal interossei are coming from the dorsal sides of all the metacarpals. These are bipennate muscles. And the palmar interossei, as I said, come from the palmar sides of metacarpals 2, 4, and 5. They insert onto the base of the proximal phalanges and also the extensor expansions. The nerve supply for these interossei is via the ulnar nerve, the deep branch, and the dorsal interossei are associated with abducting digits 2 to 4. Abducting digits 2 to 4. Palmar interossei are associated with adducting digits 2, 4, and 5. This time towards the axial line. I've put that here, towards the axial line and away from the axial line. What does that mean? Well, if you imagine the axial line is running down in line with the middle finger, so an axial line is running down here. This is the line at which these fingers are going to be abducted or adducted. And we can see that with contraction of these muscles, we can put the muscles in cartoon form here. With this axial line, we can see that the dorsal interossei are going to pull the fingers away from this axial line. So this dorsal interossei can pull it away. This dorsal interossei can pull this middle finger away. It can also, because we have the dorsal interossei on the other side, abduct it the other way. For the fingers, we don't talk about abduction and adduction as moving them towards the midline of the body. We talk about moving away from this axial line. Therefore, the middle finger can both abduct this way and it can abduct that way. Whereas the other fingers will all abduct away from this axial line like that. The middle finger can abduct away either side. If we look at the palmar interossei, then we look at adducting. So palmar interossei are adducting, and they're going to draw the fingers towards the middle finger, towards the axial line. So we can see that this interossei will move it across, this interossei will move it across, this interossei will also move it across. So we've got our middle finger, we can adduct here, we can adduct here, and we can adduct here. So all the fingers are together. Don't forget we have Adductor Pollicis, so we can move the thumb across. It doesn't need an interosseous muscle. So here we can see the origins and insertions of these muscles. The easy way to remember the function is for the dorsal interossei to use the D from dorsal and the ab, so you can have dab, dorsal interossei abduct, and you can have pad using the P from palmar interossei, pad, as the palmar interossei's adduct. So in this lecture, we've looked at the dorsal aspect of the hand. We've looked at the extrinsic extensor tendons and tenderness sheaths. We've looked at extensor expansions and the anatomical snuff box, its boundaries and contents. We've then looked at the palmar aspects. We looked at the carpal tunnel and the ulnar canal, the boundaries and contents. We then looked at compartments, central, hypothena, thena, adductor, and interosseous. And we looked at the muscles within each of the compartments. And then we looked at the extrinsic flexor tendons.